to the cloud.
There you go.
Okay.
Well, we have 6 participants. It shows a total of 8, which is 2 of us.
Yeah, yeah. I'm going to wait just maybe 2 more minutes. We'll jump in right at 5 after. How's that? If you need to jump up and get some water or something more fun than that, go for it. We'll start right about 5 after. I'd love for any of you that are on, if you're willing in the chat board, to share if you know anything about this topic, if anybody's talked to you about this topic, if you have a contract that mentions the topic. Just curious, what brought you here? And if you don't want to chat that information, I understand that as well.
You could, if you wish to just privately chat it, you could send it directly to Ginger. There's a choice of chatting to everyone.
Yeah.
In the chat directly to Ginger, the host. And it looks like that's the only chat, 2 choices you have, the way it's set up at the moment.
All right. Well, shall we get going, Joe?
Sure.
Okay. Again, thank you all for being on. I just want to say now that the recording's going, that we are recording the session. We have quite a few people who watch our webinars after the live session. And if you feel uncomfortable with your name appearing, you can always email us after and ask questions. That's probably the most likely time your name might be recorded if you came in under your name. So just to sort of start over again, this idea of what's going on with midwife contracts around the country has been I think it's been a learning curve for Joe and I. When I was the midwifery education program director at KU for many years, when we started that program, Joe would help periodically, there's Alvin, review contracts of new grads and help them out a little bit. And when I went to Shenandoah and taught there for about 6 years, we did the same. We would focus on some of the more important details of contracts that often students didn't have a lot of understanding or information about. And so now that we're approaching working with nearly 400 midwives since we started, and about 300 some plus our contracts, we of course have a very clear idea what's going on. And it appears to me, and Joe may want to talk about this from his own perspective, that more and more is creeping into contracts that didn't previously exist. A good example is we weren't talking about wRVUs 10 years ago, right? That's a fairly new concept. And I think what we're starting to see now, mostly in the latter part of 2019 and 2020, and all the redacted contracts you're going to see today are from 2020, are bringing up fair market value. And until I had a conversation with a good friend of mine, a very seasoned midwife at a very prominent university academic teaching center, who has a division and is trying to negotiate salaries for her midwife team. And the barrier was they're throwing out that I'm capped, the chief midwife, therefore I'm at the highest level of my fair market value and I'll never get a raise. I'm like, what? Wait a minute. That doesn't make any sense to me. You're going to work 10 more years and never get a raise? Like, what does that mean? And so, I just sort of took it upon myself to think about this. And really, Joe and I will be full disclosure here. We have not talked about this content we're going to share with you tonight in any of the reviews we've done. And we'll be changing that because we've learned quite a bit. And again, I feel like we're on this Mythbuster game of telling the truth, rather than my opinion is a lot of midwives don't know what they're signing. and there's intentionality for it to all sound great, but in reality, it's one big lie. That's my hardened view about it. So we're going to talk about fair market value, fact and fiction, and pretty informal. There aren't a lot of people on tonight. So if you have a question, like put it in the chat or raise your hand or interrupt us and we'll stop. We'll definitely have a Q&A at the end. But I'm curious how many of you have any idea what we're going to be talking about tonight with some substantive knowledge about fair market value for midwives? Yeah, well, that's how I felt. There's nothing in the written literature from our association, from any of the advanced practice associations. It is just sort of another one out there in the dark, hanging by a chad with midwives, I will say, marching to the tune of what they're told instead of having a sort of equitable conversation about all of this. So why should you care? And this is again, I'll get off my soapbox in just a minute. And you'll hear from me that I'm not real happy with our association about this topic because there is no current reliable data about compensation of midwives anywhere. So people make this stuff up, and it all depends upon who the vendors are that these big universities, in particular, these big hospitals are getting their data from. So I think we need more superheroes to advocate for fair compensation and equitable compensation for midwives. Joe sent me this cartoon a few weeks ago, and I thought, you know what? We do need more of those. So you're all going to become superheroes for us and spread the word. This is what we're going to talk about tonight. Fair market value involves concepts that are above my knowledge. That's why Joe's here to help. Stark law, safe harbor, a little bit about wRVUs and how it all fits into the compensation packet. We have 4 or 5 redacted contracts to show you why now we are concerned. And we're going to give you a few strategies to negotiate for fair compensation around this topic. So for me, I have to sort of understand something at a very basic level when it's not a discipline I know anything about. So other than Joe trying to describe it to me, which didn't work very well, I went out and searched. And what I happened to find was MGMA, the largest vendor in the nation, who gives out salary survey data about physicians and advanced practice providers, has a little PDF that I found, pretty recent, and this is the story. Dr. Jones is an orthopedist in a private practice, and she takes Medicare and Medicaid and provides a variety of ancillary services. Cool. I've had 2 hip replacements. I'm glad we have great orthopedists out there. She also holds a medical directorship over the orthopedic service line at a local hospital and is paid for orthosurgery ER call at 2 local hospitals. So why is that important? Well, a physician's transactions and compensation are subject to significant regulatory scrutiny by federal and state agencies and governments, and that this activity of most physicians in private practice and those employed in hospitals, of which 60% of the physicians in our country work under an incentive wRVU model, are impacted by these regulations. So there's a citation if you want to go look at it. This is a continuing Dr. Jones' story, and you can see this table, which really illustrates why Dr. Jones might be in trouble. Stark law prohibits physicians from referring Medicare and Medicaid patients for specific, and the phrase is designated health services, to entities the physician and or immediate family member have a financial relationship with. And similarly, anti-kickback statutes prevent those who knowingly and willfully offer, pay, solicit, or receive remuneration to induce business payable by Medicare and Medicaid, unless certain safe harbors are satisfied. So Joe's going to talk about how that can even happen. What I deleted from the slide deck, I've been playing with this all day, were 2 recent hospitals fined in the multi-million-dollar level for breaching components of this issue, both in overcompensating physicians and anti-kickback statutes. So Joe, you want to take it over?
Sure. First of all, in general, the Stark Law is dealing with federal reimbursement for physicians or other similarly situated healthcare providers, such as clinics and hospitals. And so we first want to look at this phrase, fair market value, that started working its way into the contracts. And fair market value has a pretty consistent definition across most contexts of law, especially anything dealing with federal finance. The phrase fair market value boils down to an arm's length transaction, meaning the value consistent with the general market of the subject transaction, which is a slight variation upon IRS holdings, et cetera. If you look for objects that are sold at fair market value, they're usually sold where one person is under no compulsion to buy and the other person is under no compulsion to sell. So this twists that definition a little bit in the Stark world, but not significantly. So they're looking for the outriggers in Stark law. And Stark law has limited applicability to CNMs because the CNMs are not physicians, and Stark law relates to physicians and physician entities. Referrals are subject under Stark, nor are CPMs providers of designated health services. So if you don't fit in a physician position, you might be fitting into the fact that you're a clinic, like we saw in the orthopedist slide, this clinic or service or practice that is owned and providing patient services. And these patient services are being billed for, especially Medicare. That's where Stark spends most of its time lurking about. And so, PT, labs, outpatient clinics, those sorts of things are the designated health services. So you have to watch about financial entanglements between those two, where somebody can be enriching themselves by virtue of what you might call insider trading. One of the few, if any, Medicare beneficiaries may be among the patient population generated under CNM physician referral arrangements, meaning you're outside of the topic of being a defined entity, and you're outside the practice area that the Stark is looking for. You want to move it forward, Ginger? The main points that set midwives apart are the fact that midwives are not physicians, so they don't fit under that part of the definition. They're not designated healthcare services or provide that kind of service, and they don't treat very many Medicare patients. Go to the next slide. And as we know, it only applies to Medicare patients, and it could be applicable to both but it could be applicable if the following are in place. The midwife practices through a physician practice, and the practice is paid by a designated health services entity. So you could find yourself entangled into the Stark conversation by participating in a physician practice and a practice that's paid by a healthcare services entity, but you wouldn't be directly involved in that. So in other words, that has nothing to do with your fair market compensation and salary. These limited risks have nothing to, so it's not a fair market value question. So later when we start looking at these contracts and the context that got us going is we've looked at the average pay based upon a database search, and we're going to pay you this amount, the average, because that's what the fair market value would be, which means you're, a race to the bottom of the lowest common denominator as far as compensation packages, without regard to other markers that would make you worth more than other people in your own profession. Obviously, you're going to have people, the bell curve of profession, and it ignores the standard deviations on the upper side of that bell curve. You can move forward. they wind up mixing the concepts of anti-kickback and stark law, and to confess, we did too when we got started looking at it. We thought it was a stark law issue, an anti-kickback issue, and then we started trying to figure out the difference between the two, because they're both chosen to regulate parties that have a financial incentive to generate and receive patient referrals from the other party. They're looking for the same kind of, they're both regulatory throttles on commerce to keep people from creating this reciprocal relationship that runs bills up inappropriately. The anti-kickback statutes have more applicability to midwifery than the Stark Law does. As we've seen, the Stark Law really, it's hard to, you got to be basically an accessory kind of role in order to get into the Stark rules. But anti-kickback has a broader catchment area, and it involves all the federal healthcare programs, so especially Medicare and Medicaid. And much of what midwives do have to do with Medicaid, not Medicare. So you wind up with the potential under anti-kickback statutes of felony charges, et cetera, if you offer to pay, solicit, or receive any remuneration to reduce or reward referrals of items of services reimbursable by federal healthcare programs. So you notice the activity has to do with pay, solicit, or receive any reimbursement or inducement for referrals. So again, we're going to talk more about this as we move on down the slides, but we're really looking at a compensation package that somehow rewards referrals.
Yeah, Joe, let me jump in here and see if see your opinion on this, and anybody on the call. Let's hypothetically say you're working at a federally qualified health center that also has a birth center, and there's about 5 of those, 6 of those right now in the nation. And midwife A is compensated on the number of births that she keeps at the birth center instead of referring to the hospital for birth.
Does that ring a bell or cause scrutiny?
Yeah. For anti-kickback.
It would be a referral to look into exactly what that means, because we have also the idea of the inverse of you're compensating them for not making a referral, which means you're
compensating them for making a referral, because the birth center is going to make that money for the fee versus the hospital.
Yeah.
I don't know.
Get a red flag when you have anything in which the concept of trying to manipulate the natural flow between these various care providers and entities.
Yeah. I'm still learning, y'all. So I'm sure you have questions too. It sort of begs the question about wRVUs. If midwives are going to, Joe, as I was talking about this before we started the call, if midwives are being incentivized beyond their base to work, and they're paid on a wRVU model, but then they find out that they've made more than the fair market value that agency determined they should make, they're like at the 90th percentile or higher for the given salary, and they take the money away.
Well, the devil's going to be in the details, and we'll get to that here in a moment in a slide that's coming up, because you have the safe harbor issue. There's nothing wrong with what we call, when we summarize, an eat what you can kill contract, or a contract that compensates people for the greater effort you put forward, the greater money you make. Where you get some level of question is when the compensation starts working more and more blatantly towards did not refer, because did not refer theoretically would be the same thing as referring in the sense of you're tinkering with that economic exchange. But there are safe harbors that and some criteria that we want to look at here in a moment. So the anti-kickback statute applies when referrals are generated by one type of provider and applies to all federal programs, including Medicaid. You can go on with the next one. There are safe harbors within this broad rule in almost all legislation, but almost all federal legislation, especially those around regulation and compensation, starts with a general rule, whether it's a permission or a prohibition, and then has exceptions to that general rule. So you say you can't do any of these kickbacks broadly, and then you have safe harbors, and by safe harbor, what we mean is the exceptions to the rule. So here we have you have compensation for bona fide employees, and that it would be the normal IRS definition of what creates an employee, for figuring out FICA, for figuring out all these other things. Is the person working at your direction at a schedule set by the employer? All those accoutrements of employment. The compensation is not part of that, as long as that compensation doesn't relate directly to referrals.
And we're going to see that in one of the redacted contracts.
Yeah. So if you are compensated by bringing in new patients, that's different than caring for more patients than anyone else. And there's a gentle edge here. Our daughter-in-law is working for a rural health clinic and small hospital in rural Kansas, and there's a billboard outside of town in which her face is 15 feet high, saying, "Welcome to our community, Dr. Haynes." And that is not a referral-based marketing scheme. It's outside of it. You can advertise, and you could individually advertise, or your clinic could advertise. There's a new sheriff in town, basically in the midwifery world here. Come see us, and that has nothing to do with referrals. You're not noodling around in that interconnection. Independent contractors, and this is important in two contexts. One is when midwives are working as independent contractors, and also when we have independent contractor relationships with, for example, we'll hit on it briefly, the idea of compensation and how you compensate for collaborative practice agreements. We did have a question. I thought I would hit this real quick. It had to do with sponsorships from companies or discounts for being healthcare provider who directs patients to certain products. That's outside of these two concepts. The federal government is looking for trying to cut down on waste and graft in Medicare and Medicaid. They really don't care whether you sell Pfizer risers over the genetics. It would be just whatever happens there in the market, and that's they're unlikely to go regulate that for a while, about like they're unlikely to engage in significant gun control. There's a lot of money to be made in that world. Compensation for independent contractors you do need to have a writing so that the rules are clear, and it does not relate to referrals, promoting the business arrangement, and consistent with fair market value. So you see fair market value for the first time in this conversation being relevant to a midwife conducting business, and then it's as an independent contractor, and if you have some kind of unreasonable compensation rate, you're going to raise a red flag, and the services must be commercially reasonably necessary. So that's the only time you're going to wind up with. This would be a situation where you have a key individual who's working as an independent contractor, and obviously you're having to deal with specific referrals for specific contexts. So the relationship is tightened over what it would be to you come in and clock into your birth center, or you're open for a practice, and your compensation is based on all those things that we'll look at in a moment that have to do with being an employee on a day-to-day. And you'll see the obvious things are going to be things like fringe benefits, expected hours of work, expected call hours, those sorts of things. So, let's say you have somebody who's somehow, maybe made a movie or something, being one of the world's most wonderful midwife, and now they're out there offering their services at a per person specific trying to bespoke service that would be happening. If you're doing that and noodling around at the same time with Medicare and Medicaid, you got problems. You don't have problems saying, I'm the coolest midwife, I've been on TV, therefore you must like me better than anybody else, and therefore you'll pay me out of pocket 4 times the rate of what it would cost you otherwise. That's perfectly fine. That's the marketplace. But if you're going to turn around and try to churn business off the federal government tab, that's where you're going to run into trouble. You can go on the next one. Really, it's hard to find justifications for these caps. And by caps, what we're saying is we have seen contracts that discuss fair market value, and then we've seen contracts that say, like I said before, they go and mine some kind of database and they say, we're not able to pay you anymore because it's above the fair market value. And if you go back to the definition of fair market value, looking at averages or looking at ranges of compensation of others does not fit well with the definition restrictively. What it does fit well, if you have a good enough database, which Ginger will probably talk about here and then as we go through here, is it gives you an idea of what a reasonable range is. So just to be a dumb analogy, we decided that we needed to get our house painted, and we've been avoiding it for a few years because we imagined it was going to cost us $10,000 to $12,000 to paint our house. We go out and we get a few bids, and we find out that the bids are ranging between $5,000 and $9,000. Well, now that we understand what the fair market value is, our imaginary painter that was for $14,000 or $11,000 would ring a bell as not being fair market value unless they bring something new to the table, like they were Picasso's grandson. God help us through the Homes Association for that. You'd have to come up with something out of the blue. And again, you're mining these relationships, and you're going to run into trouble if the fertile ground is federal reimbursement. Next slide.
So Joe, what if physicians are mining midwife patients who are, let's just say they're Medicaid, because they don't have enough and they're going to take them away from the midwives?
Well, if it's not a referral, but a work distribution, you're not going to have a problem.
So they can take them. The physicians can take the patients,
right,
who have established care with the midwives.
Happy Beginnings Birth Center and obstetric practice owned by 2 docs and employs 6 midwives over 3 locations within the business model. There wouldn't be anything that keeps you from having a Stark issue or a kickback issue because it's not between 2 separate.
Okay, it's all in one.
Yeah. And so you can say, I'm going to.
Okay, you all go start your own businesses. I'm getting madder by the moment.
Look at my law practice.
No, I don't want to.
Well, but it's a good example. When things are very busy, I may delegate more work to my paralegal to do, and we bill her as $150 an hour. But if I have a client that wants special attention, or we're not as busy, I might pay attention more to that file at $400 an hour. And so that's just the workflow and distribution of what's delegated. And then you get into the vicarious billing, for lack of a better word. You have a term of art that you guys always use.
Incident to
billing.
Yeah.
Where the physicians are billing literally the full boat for the physician having delivered, but the midwife actually did it as an agent.
Yeah.
And then outcome-based payments are permitted. So it's permissible to bonus or penalize on an outcome measures, but they must be, and this is the safe harbor kind of logic, based on clinical evidence or medical support. So you're rewarding or punishing people for doing their medical professional role appropriately or not. Quantifiable benchmarks for patient care or cost reductions. So if you can say that you somehow manage to use fewer resources to push babies out, and therefore it's more profitable, you can be paid more from your entity. So you can see why, if you just go back to the basic idea, the federal government has no axe to grind if they pay you whatever the service is for $2,000, and you're trying to work your business to have a profit margin where you get to keep 1,000 of it at 50%, as opposed to 40% profit margin or 30% profit margin. As a matter of fact, they have incentives to want you to do that, and then not based solely on internal cost savings or patient satisfaction. So what we see in a lot of these contracts is exactly this 1, 2, 3 punch. We're doing a bonus system based on, and then they'll have some markers for clinical evidence and medical support, benchmarks for patient care and costs, and then they may also say cost savings and patient satisfaction.
And we see that in numerous contracts.
We did one, Ginger, you'll recall it, they had a set of, there were like 2 or 3 in a row that came up. They had a set of tables, and patient satisfaction and internal cost savings were like 5 or 6% of the total bonus. But they rewarded for it, but they hit this safe harbor. You can clearly tell.
Yeah.
Whoever wrote that contract read the
now that we know.
Right. So this is a moment in which we kind of pause, and I will go back and give you a little bit of a review, but also want to open it up. There's a question here, and I want to get to it before I continue to. What if we take a percentage of incentive bonus based on pay? Oh, I think I just answered that. If Shauna, if I didn't answer that, let me know. But I think I just hit on that about the same time you were talking or typing. So when somebody says we can't pay you or your pay is regulated because of Stark, it almost can't be true because you're not the designated health service, and you're not a physician. And while their compensation may need to be managed on a fair market value, they're probably not actually doing they're not doing a market average for these physicians. You see some key practices where they go out and they push the market in order to build a book of business. Cardiologists in this area were famous for that.
They're in the biggest trouble right now, by the way. There are more issues with cardiologist groups than anybody else right now related to these issues. I'm
sure, because no matter what other physicians make, these cardiology groups, we have some in the metropolitan area of Kansas City, which demographically is not way up there, but the Johnson County area is way up there, but the whole community in Kansas City is not. And you would have these providers where individual providers were being paid somewhere in the bracket of $1 million a year. It was a combination package of being you know, a little bit for being department head, a little bit for some kind of stipend for teaching, a few things like that. But you know, you start handing around $30,000-$40,000 a month in compensation.
Yeah, the Dr.
Another
Jones
10 or
case.
12,000 a month to it.
Yeah.
So it begs question on whether or not these physicians who are making, and the cardiologists in our area, because among other things, cardiologists seem to suffer divorces at a pretty great rate. I've worked with them that are in the $380,000 bracket working for federal agencies, all the way up to this $1 million bracket. And in theory, they're all similarly qualified, similarly situated professionals.
And that would be where you get your percentile brackets from these big data groups we're going to talk about in a minute. What percentile do they fall in for their specialty?
But it doesn't, the point here is it doesn't designate that that's not fair market value.
No, it's just what is the salary range?
Right.
It's one variable.
If you're the last hospital that doesn't have a whiz-bang cardiology unit, and you want one in place this time next year, you're going to go find somebody and recruit them and compensate them way out of in the top standard deviation. But fair market value, in my opinion, can include the entire bell curve. When you get 3 standard deviations off the norm, you start having problems. But you get that the fair market value represents a stratification of a variety of reasons why people are paid different. And that because it's a dynamic concept. If you wanted a static concept, you would have to somehow develop some kind of criteria on which pay people.
Exactly.
That would be a direct entry into some of the fears for managed medicine, etc.
Yeah.
Having said that, obviously Stark is, you're going to have to somehow be an accomplice to some kind of direct Stark violation and probably have to know something about what's going on. And anti-kickback is going to definitely depend upon at least a significant element, not of fair market value in the slightest, until you get to the independent contractor phrase, but on whether you're being compensated for doing your job or whether you're being compensated for referring or recruiting patients directly. Are you, in other words, are you working on a commission?
Exactly.
Or are you being compensated? The harder you work, the more money you make. And those are 2 different concepts. And we'll talk more about why these contracts work in strange ways. Ginger, I think this is a part you were going to pick up on.
Okay. So what is the standard setting we're talking about where the percentiles for physician salaries is collected nationwide? And we talked about this a little bit on the wRVU talk. There are 4 main companies in the US, and the 2 that are mentioned the most are MGMA and Sullivan Cotter. And I may have shared on the last webinar, I tried to get access to the 2019 data before the wRVU talk, and they wanted $11,000. So I went around the end run and tried to find everything I could on open source information. But I will tell you this, we believe there is no national data set that can be generalizable to midwives in our country. There simply isn't, and I'll show you why in a minute. But the latest Sullivan Cotter data only reports 1,000 midwives working in a variety of settings and does not include, and I did this homework for the midwife I was talking to you about a minute ago, working for a big university academic teaching center. None of the Sullivan Cotter data applied to a university or medical school setting where advanced practice providers worked. And all of the advanced practice providers in the Sullivan Cotter data are described in one N. They do not split out like they do the physician specialties. So, you know, it's a comparison and a data point that you would think could be to our advantage, but it doesn't seem to play out that way. What did CMS say in the new 2021 update on fair market value? And I lifted this out because I think this is really important when I was doing my search on advanced practice providers and fair market value. This highlighted section right here proves my point that CMS believes that fair market value transaction may not always align with published valuation data compilations, such as salary surveys. They're speaking directly to the entities that hospitals are using for salaries. And the rate of compensation set forth in a salary survey may not always be identical to the worth of the physician's services. That is true for any provider that they're using their data sets on. It's a really, really important point. And if you're going to be a superhero and negotiate this, if it appears in your contract, this is a quote you definitely want, because
Let me interject.
Go ahead.
Also in 2021, Stark regulations were adjusted, and I think this correlates with that. You have regulations defining fair market value to be the value at an arm's length transaction consistent with the general market value of a subject transaction. So they changed they revised the Stark that took, when this revision takes place in January of this year, to mean, they clarified it and they said the compensation that would be paid at the time the parties enter into the service agreement as the result of bona fide bargaining between well-informed parties that are not otherwise in a position to generate business for one another. So we're back to this conversation where we use the cardiologist as an example. If you're going into a midwifery practice and you're talking about how much you're going to be paid for professional midwifery services as a job, and you're asking to be employed, that's bona fide bargaining for the position. And this is dealing with the regulations that Stark has, and this conversation applies most directly to physicians. And again, remember, Stark doesn't apply to midwives. So, there's a broadening of that conversation and the clarification that no, we're not going to look at how much Joe is paid by looking at how many other people that do the same job as Joe is paid. We're looking at the economic relationship and what the basis of the motivation for that payment package. And it just can't be the idea of generating a mutual love affair of generating businesses.
So Joe, I think there's a question that came up that's going to directly be this slide we're on now. So I'm going to read the question.
Yeah.
Can you speak on how Stark law and anti-kickback may impact an independent midwifery practice that is attempting to establish a collaborative relationship for backup call coverage, and how it treats referrals from an independent C&M practice to the collaborating group for GYN surgical patients and C-sections? This is sort of where Leslie was having us look a little bit deeper into. She's an independent owner of a large birth center, right? And how does this impact collaboration agreements to the physician?
And it's appropriate to have, if you're going to have compensation for the collaboration, it's appropriate to have a fairly thorough review of what that means and why, and what the compensation is. Because
what it's for.
Hmm?
What it's for.
Right. Because you are walking directly. I mean, one of the reasons why a physician is going to want to collaborate with you is that it is a introit into referrals and more business. They wind up with a physician relationship with anybody that they're collaborating with that's moved up into that range of care needs. And so they're there. And they're catching this business by virtue of their position as being a collaborator. Collaborative physicians probably can't really say, you're pre-eclamptic and you probably got 10 minutes left. You really need to find a competent provider. Instead, they're going to start issuing medical orders. And so, the role of that collaboration is to take on that care providing role. So as long as you're not, the first step of how you're obviously going to get into some risk in anti-kickback would be paying the midwives or back for patients that come to you is a kickback, and probably one that's regulated against.
You mean the independent midwife sends a patient to Alvin, and
Right.
Alvin gives the midwife money for sending the patient.
Right. That's a
Okay.
kickback.
Right. I just want to make sure everybody understands this. Right. Versus
And
I'm going to pay Alvin $5,000 because I have to make him feel good. And he's going to get that $5,000 for the year, but he's also going to get all the patients that I can't take care of.
Right. And in the last scenario is probably okay. The first scenario is not.
Yeah.
But any creative, if you're not paying for the collaboration service, or that it fluctuates based upon the activity, you're going to want to have somebody review it.
This is what some of the literature said, Danielle, that I was looking at today, because again, Dr. Jones, the orthopedist we talked about in the very beginning, began to percolate in my mind about the maternal fetal medicine docs we consulted with when we started the Kansas City practice, which grew to be very big, 10 midwives. These maternal fetal medicine physicians were a part of obstetrics with an X, which has gone on to another permutation of a venture partnership of MFMs around the country. So they ran a maternal fetal medicine department. They were paid by the hospital to sit in their building. They were also paid to be obstetric educators for the residents. And they were paid to be consultants to the midwives. You see how these layers are adding up here. And all their ultrasounds and the genetic counselors were employed by the MFM group. So all those referrals for designated services came right back to them. And it would be, I would think, more of a concern to the physicians. Are they stacking too much for their salary to be too high if they're employed by a hospital or an entity, not if they're in private practice? Nobody gives two sheets to the wind. But if they're employed by the hospital or a large entity, they may be concerned about that more than you. Would you agree, Joe?
Yeah. Well, because anti-kickback is criminal in nature, it's important to understand that if you're creating a context that could have criminal liability, you would want to make sure. There's quite a conversation about whether collaborative physicians should be compensated for this service at all.
We say no.
Yeah, and you're obviously not nobody has any problem if you don't pay them any extra for doing this. And you can see why there would be, if midwifery services were those designated service providers, or if they were, or if midwives were also under the Stark umbrella, you could see how this would be just a classic closed referral system that thwarts the free market. But if you look at it as it really is, and a necessary component to a continuity of care, the usual species is of course you'd want to do this. You're going to wind up with a bunch of business landing in your lap that you otherwise wouldn't have.
I'm going to keep us going, Joe.
Yeah.
So how does this impact midwife compensation? And I apologize for putting CNM. I should have put midwife. And you're going to hear some repetition here for the rest of the presentation, so we won't belabor it, but there are key points that I think you need to know if it appears in your contract, or if you're in the position of negotiating right now. So large institutions and physician-owned groups are using that to limit midwifery compensation without transparency or rationale for why. They are using third-party resources, the ones that CMS said are not necessarily reliable, that do not align with midwifery salaries, work hours, location of practice. And the hard cap on salaries for this midwife that runs a division doesn't include any of the teaching she does for the residents, the extra work she does for the incoming interns, the grand rounds, and a whole lot of other things this person is doing. They just say, well, we're really glad you do it. She's getting no compensation for it, and it's pretty furious about that. So what can you do to increase your ability? Well, this one I think is really, I don't know if Joe has a way to maybe finesse it better than my boldness of just help me understand. There is a requirement in law that there has to be reasonable knowledge about the facts when it relates to fair market value. So between the buyer and the seller, or you and the person that's going to be employing you. So it is a reasonable request by law to ask the potential employer or your current employer, how is fair market value determined? What are the data sets you're using? What are the percentile ranges that you are determining? And for you to have an opportunity to counter that. And that will never happen if you don't ask. But you do have a legal right to do that. So here's the problem with our salaries. And whenever I work coaching people, I take a look at all of this stuff. The Bureau of Labor Statistics, which should be coming out soon in another month or two, first of all, does not include the certified midwife. And many states still, every time I look at that, don't even report. Like Kansas, it's embarrassing. And we have probably over 50 full scope practicing midwives in our state. The Medscape annual survey comes out, which you see in any of the presentations I've done. I update those every January, which gives a variety of what they count as average salaries. They probably collect more data than Cotter Sullivan does. You have to pay to play with those survey entities. Like I said, they were going to give me my little Grow Midwives company, and I had to disclose quite a bit of information to them. Oh, just a little $11,000 to see their survey data set. So I cannot believe that there isn't a little bit of shenanigans going on there, or the possibility for that certainly exists. My frustration with ACNM, you can read it, I won't say it out loud. And the potential differences in all of these reporting entities, and then just layer that on with Indeed, Glassdoor, Zip Salary, go look at all of those. And then people who write about midwife salaries who aren't even midwives are so frustrating to me. It's all over. We have no clear data on midwife salaries. And so just to contest that by the fact that it doesn't exist is a point you should take. And I promise you the demand for midwives is growing. Those of you not out of school yet, the demand is growing, and that should be used to your advantage. So what about non-billable responsibilities? This gets into a little bit of what I was helping the midwife with related to the other things she's doing. Well, there are regulations that would advocate for her to be paid more for that under fair market value, and that it should be reflected as a higher salary. So to say that it's not is unfair, and there's actually a little term used called the burden factor. Are you running a residency program? Are you running a midwifery program? Are you responsible for coordinating CE for the department? Whatever those additional administrative non-billable hours are that you do should be counted in some way.
And please recall that this conversation is marginally appropriate. you're dealing with stark regulations for somebody who isn't under stark regulations. But if the entity is bound and determined to speak about compensation in this language, and you want to be able to talk their talk, this would be the conversation, the way to frame the conversation. But the first principle is you're not even talking in the right. We're not even shouldn't be having this conversation.
Exactly.
You're off point.
You didn't feed the dog?
I haven't fed the dog.
Got it.
So these additional points here, I think we've already highlighted. I don't want to belabor them because I want to be able to get to some robust questions here in a minute. But it is important that you know that the employer must be transparent if you do go into these conversations. It is your legal right to be able to understand what database they're using and how they've made these decisions. So here we go. Here are some redacted contracts. And I was sharing with Joe when I found these yesterday. They are increasing. These are from 2020. In the search of our database, we'll probably have 10 to 15 contracts we have seen with fair market value mentioned. And some of them make me really mad. And I don't think Joe agrees with me, but that's okay. Providers' total compensation must be reasonable and meet regulatory standards for fair market value.
Okay, stop. If that was the clause 6, you could agree to that because, as we've talked about, there are no regulatory standards. So you'd be fine. If they evolved and became relevant, you agree you would follow those regulations. But here's the problem in the construction of this paragraph coming from the perspective of the lawyer, is there's a full stop here after that sentence, and then the next whole set of the compensation board committee and what it can do in its whole discretion, etc., is not directly related to the principle set out in sentence 1. It is not related to regulatory standards. So you've gone from regulatory standards controlling fair market value into a different topic in the remainder of this paragraph. And it is the compensation committee or board committee determination of what they think fair market value ought to be, without regard to whether or not it fits the regulation and if there's a regulation. So, that's the kind of thing that a lawyer could look at and go, you didn't write that very well, or you wrote it real well for your interest. That was
right. Meaning no matter what, an unknowing midwife is going to be taken advantage of. That's my take.
On a obscure criteria based, these are at will employment agreements that they're
right.
So,
right.
So, they could say we've decided we're going to cut everybody's salary back by 20%.
Well, here's the next one. Why would I sign this? Probably I didn't read it. The parties acknowledge that the compensation provided under this agreement is intended to reflect the fair market value for provider specialty and call coverage, and does not and will not take into account in any way the volume or value of referrals or business generated between the parties.
I disagree with Ginger's feeling about this. I think this fits exactly in the ballpark of what we want, and especially if it was an independent contractor position. What it's saying is we wound up with this bona fide negotiation and exchange for the compensation, and even if it does run squirrely to other things, we together stipulate that this is a fair market value.
How does a midwife know that it's fair market value?
Well, that isn't the purpose of the clause. Is not whether
it says under this agreement,
right,
that we acknowledge that we're signing something that says $85,000 is fair market value.
Well, it is if you sign it.
Well, that's my point. It's like,
what's something worth what the next person.
Oh, it's so frustrating.
It doesn't have the zinger that the previous one did.
Okay, so let's look at another one.
Control and not connecting things. All it says is we believe we did things right.
This one is long. What do you think about this one? They're like covering every piece of the issue.
And again, you're delving right up the skirts, so to speak, of fair market value in your role, when fair market value is probably not a criteria at all.
Exactly.
So this is the kind of clause where you would say, not so sure that I wouldn't suggest you strike the whole thing. Or state, under current law, fair market value is not a criteria. If it becomes criteria, here's the rules of play.
Any midwives on the call right now willing to go into this kind of negotiation with an employer, I mean?
While we're waiting, I would say this is the kind of thing that we see when we see contracts that are designated for all brands of providers.
Exactly.
And some of these contracts that we see are for every single healthcare provider in the system.
Right.
And then there's an exhibit that says your role is midwife. So
Yeah.
they're wanting to put all of the physician specific
That's right.
safeguards in there, or clauses, and a one size fits all contract. And they have to figure out whether that makes any sense to you or not.
So can I jump in, Ginger?
Yeah.
Do you mind? So there's a couple of things. First of all, as in nursing, and I don't want to generalize to everybody, but for the majority of us, when we worked as a registered nurse, you didn't have contract negotiation authority. And so I think that in midwifery, we are probably come into midwifery socialized with that same kind of concept that we really don't have a lot of bargaining power just because of our history. That's number one. Number two, when I try to tell myself, oh yeah, I'm going to read this legal mumbo jumbo loses me after about the second methodology set forth herein. I don't even know what they're talking about anymore.
Right.
And number three, I think that we do not encourage our peers, certainly our students, to take a minute and go get legal advice before they do this. And I think it kind of goes back to the same thing that I said. We don't even think that we have the authority or the right to negotiate for these things because of the hierarchy of our profession. And so I'm thinking that we need to start having some very robust conversations within our professional organization. Because the other thing, Ginger, when you were talking about there's no data out there for midwives, is there any data for CRNAs? Because I've been pondering.
You better believe it.
So why can't we as a profession, because we take call, we are in the hospital, we do more than they do.
Yes, we do.
Can we not use some of their tactics?
We
to
need more money.
negotiate at
We need
some
more
point?
money, and we need somebody to conduct a national survey and analyze it.
Okay,
Yeah.
tell us where to start.
And there's probably a limit to who you can get referrals from. We're offering a mid-level service. Because I practice law, we start all of our contract reviews with, we can't give you specific legal advice. We're relying on general information, blah, 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 blah. And, I can't go and advocate for somebody if I'm not licensed to practice in that state. And, we're doing contract reviews sort of on
An academic level.
And as an academic level, it sort of intones a little bit of superficiality. We're certainly not getting into the grit of the politics of a particular employment relationship, etc. But as off center as midwifery is in the stream of healthcare at the moment, you really have to be careful on who you're getting advice from, because they may not understand the nuances of midwifery as opposed to orthopedic care or even a nurse anesthetist.
So here's another one. This may be the last one, talking about total annual compensation from the company for each employment year may not exceed the fair market value. And they're not going to include your health insurance as a benefit to what that salary might be. And they will make a determination if the compensation shall be lowered pursuant to attachment C, which is this laundry list of things that would just be totally confusing. But again, I think if you know, as we move forward, we're going to be adding our comments about this construct. If it's in a contract we look at, I'd be having lots of questions about this.
Mostly want to strike it for all the things tonight.
Yeah. So this is some strategies from my brain, and Joe might want to massage these a little bit. How do you negotiate a new contract? So you're not in a situation right now. Ask why fair market value is included and how they apply the rules to midwives.
And then you
Not
get,
a physician.
if you're being a manipulative conversation, you're waiting for them to say because Stark requires it or something like that. And you can say, well, you know, I've looked into this and Stark doesn't require it.
And that's gets down to 2 and 3. Seek their understanding. You're gonna pump them a little bit. Well, help me understand. Maybe if you explain to me why, that will help me understand your position, and then you're going to get something, and you counter with your understanding. So if they're unwilling to remove the clause, which is what we would suggest that you do, you have a legal right to ask for the national data set that they're basing the fair market salary on, and that you want to see the comparative data of the geographic location in the country, where the job is, the scope of your role. Are you just doing GYN? Are you doing full scope? Are you a midwife laborist, you know? And the entity you're employed by, because those are the variables that drill down the details of the fair market value percentiles that they're looking for, that they're going to quote back at you. All of that should be shared. And if you're in an existing relationship, go ahead, Joe.
Pointing out that fair market value based on these regulatory schemes, if they're not compensating for referrals in any way, boil down to the fair market value is what I'm willing to work for and what you're willing to pay me.
Yeah.
Period.
I have a question before, on that last slide, Ginger, when you talked about the entity variables,
Yeah.
is that like, do you mean they're like, what are they paying other midwives?
The entity is who's the employer? Is a university, private practice, community hospital, community health center. They all have very specific subsets. Like an FQHC is not going to pay, if y'all don't know this, as much as a university academic teaching center. They just can't. So those variations are not unusual, but you need to know what data they're driving their decision from.
Therefore, if you're working for an academic institution, your salary should not be measured against or compared to a federally qualified.
Right. And if you're in an existing contract, like my buddy, and you've hit the cap, then you need to go through that whole list of questions and find out what their understanding is of the regulations and how it applies to you.
So all this conversation, they come to you you've signed this contract, and now they've come to you and say, you know, we got to knock you down 10 grand a year because of fair market value. Then it's, instead of negotiating for the rules, now you're in a position to be able to say, based on our contract, you've got to support your reason for doing this. You know, granted, they could just say we're knocking your salary by 20% because that's what we're doing this week.
Yeah.
Because of your employment relationship. But
Is that will? Yeah.
The contract, then they
go start your own business. And I think I have some friends on here, at least 2 of them that I know are doing that very thing. And then there's all these other barriers, you know, that in some way can enter the conversation. Well, vicarious liability, you know, got to pay more for our malpractice premiums because we're backing you up. Restrictive scope of practice. I got to be your supervisor, sign your charts because you can't get full hospital privileges. You know, my point, we have very poor salary data, and we have yet to monetize the value of midwifery in this country. We just haven't. There's no data I can give you. I can give you the ranges. And in fact, I gave that to somebody today who's negotiating for a large practice in Ohio for a PRN CNM to come on board. I can give you the ranges because we've got the data now, but I don't think anybody else does. And that's not good. That's just not how we want to move our profession, right? So there's some resources we have available to help you. We are reducing significantly the price of the Vicarious Liability Toolkit. It is a complete, exhaustive, comprehensive review of vicarious liability and midwifery in our country for the last 10 years. You can download it in the store online, but wait a couple days till our IT people get that price way down. There's a white paper on this topic that we've introduced to you tonight. That is a complete legal analysis that could be shared if someone wants to go, well, how do you know all of this? That will be available for a very small fee. Combined with a webinar on wRVUs, which I think has been watched over 400 times now. That is really escalating. And I'm glad to know that because I don't know who's watching it, but we need people informed, Kate, as you shared. And the last thing we're excited about is our web design is about ready to launch this new Proforma for midwifery startup. So if you do want to start your own practice, we can help you with that financial data to create a Proforma and a business plan if you need to secure money. So there's the quote, Kate. It's done.
Beautiful.
We're open for some
Oh, which
Q&As.
ones Kate did?
Which ones Kate did? Kate did this one right here. She's the master quilter, and she did this one down here.
And
this is going to be auctioned off at the PAC auction at the annual meeting.
Ginger, on that last slide, when you talked about the white paper for a small fee, will it be on your website? Will we
It'll be on the store. We have a store. We're about to grow it. So that we hope that happens in the next week, that we get those up and the prices down. And the last thing I would just say is if you value what we're doing, we love to hear your comments on social media. It means a lot to us. We think we're doing good work, but it always helps when you share that with other people. So let's just open up the mic. It really is a very small group here instead of the chat, unless you want to use the chat. And if you have a question or a comment, let's talk a little bit.
Ms. French.
Hi guys. So I work in a net collections midwifery practice that is owned by the hospital where we do our deliveries. And there are sometimes when, because of their being our operators, there are expenses and processes which affect our bottom line. So the latest example is they switched from Athena scheduling and Epic charting to everything Epic. And because they are not getting the patients billed in a timely manner, we were $50,000 down for last month. Well, that was a very busy month, whereas if we were just getting everybody paid through, we would have probably received a bonus because we make anything above our overhead, we can split. So is there any way to address this that you would suggest when the institution's policies affect our bottom line?
I think the first thing I would look for is if there's a written agreement about what the shared responsibilities and duties are to fly spec that and see whether or not there's something along those lines. There's always
like a timely statement,
or just what their job is. You know, we've agreed that we're going to take on this task, and here you have a situation in which for whatever reason they didn't accomplish the task. So if they promised you they're going to do this billing and that some of your compensation is based upon reaping the rewards of accurate billing and timekeeping, it seems to me that you have a pretty reasonable basis to have a conversation. And I would watch the notice provisions, and if it becomes much more of a conversation beyond just getting the happy words back that you think might work out, officially say, we're wanting to know what's going on based upon whatever the notice provision in that agreement is, like a written concern to whoever that person is in the contract. Often it's the CEO. You notify them of a breach, because there's a breach of the contract. That's without question. But the question is, do you have a written contract? Because you have this ongoing understanding, and that fits within the confines of contract law.
So when we brought it up to our office supervisor, what they said was, well, there's not technically a problem because you guys will receive that amount of money from these bills. It's just going to be several months down the line. And I said, that's great because we did the work, we should get paid. However, not getting that money at that specific time period is what is in danger, what took away us receiving the bonus. And they just said, sorry about it. And that's it.
Well, that may be part of where you're talking about who you have a responsibility to connect with. You're talking to the next person up in the chain of command, and politics within organizations teach us to go up the chain of command. But if there's a written agreement, it may say who you're supposed to give notice to, and that may be somebody like the CEO. You have a number of problems there, including the fact that if you're compensated basically for beating a certain benchmark in a quantified time period, how do you know that compensation comes through if it's spread out thinly over the next 6 or 8 months? It may dilute itself to no value and you lose it. So, a compromise might be to say, we're expecting to see, in addition to whatever else we would have earned between then, this level of productivity bonus somehow come through the pipeline. And how are we going to do that? Just getting into brass tacks of how it works. But yeah, probably the most unexpected thing you might hear from me again is that idea that these contracts have notice provisions that are very specific, which often let you jump the chain of command. And if somebody's upset with you about it, you say, well, you gave me this contract and I signed it. And it said, if we have a contract beef, it goes.
Yeah.
Your individual employment contracts may actually relate to that. And most of them we see say, send something written to the CEO in a way that you have confirmation that it comes back. Some are very specific. They want certified mail. Others just say, we want to make sure that everybody knows it got delivered, like email.
Hi, both. So just a quick question. So would it be fair to say that they're using fair market value as selling it to, I guess, a new grad or a nurse midwife as a risk management tool, when in fact it really is more of a cost management tool, in the sense that with the last year being what it was with the pandemic, are they using this as a cost management or cost mitigation tool to recoup any of the losses that had in the elective surgery phase, in terms of hospital and medical hospital systems and medical schools in that sense? Is that why you're seeing an increase in the inclusion of fair market value in contracts? And is that driving the addition of the fair market value into contracts in the last year or so? Or why is that the increase?
It's a great question. Let me take a stab first, Joe, and you can give your impression. We don't have enough yet, Alvin, to completely answer that. And I think what we're beginning to notice is the ones that just apply to all the providers within a system, and they don't modify or extrapolate non-physician from physicians in the totality of their agreement. And some of these are 35 pages long. We're not talking about 2 or 3 pages here. And why you need that kind of a contract for a midwife, I have no idea. But I know for the person I'm trying to help in the big academic center that it predates the pandemic. She's been trying to get a salary increase for a couple years. for herself and for the other midwives, and has just keeps hitting a wall. So I don't know. I think it could have some effect, but look, there's no literature anywhere on the subject matter. So if it's cost mitigating instead of risk, wouldn't you think risk mitigating literature would exist? I don't know.
I think there are two causes for these things working their way into the contracts. One is baffle them with bullshit.
Yeah, that's my opinion.
That's it. Just, we're gonna come up with this scheme that sounds good, and it's, and somehow you buy into it.
Trust us.
You limit your marketability because you just got baffled by this concept. And that was the main thrust of this seminar. The other would be that authors of these contracts, and they by authors, you kind of have, it could either be one person in a law firm or a group of people in a law firm who handed out a contract as though from on high, or it could be a coordination between non-lawyers and lawyers trying to figure out these problems and bringing problem sets to the table. And then you are misapplying it to the midwife institution relationship. And either because they don't understand the difference between a midwife and a new physician, or they don't or they're trying to write contracts. Institutions tend to like to have contracts that are written that apply to everybody. So they have uniformity, they have consistency, and they don't go back and pay some law firm, whatever, a few $1,000s to come up with a new contract when they just when they could just print a new one off and put a new name at the top.
We even see some with the wrong names on them.
Oh yeah, we see
Wow.
many contracts that are designed to cover every healthcare provider in the institution. So you have
NPAs,
clauses.
NPs,
Yeah,
nurses.
It just seems suspicious to me. And I'm a new midwife to be, and I will be going into contract negotiations in the next couple of months as well. It just seems suspicious from my perspective that this is becoming more prevalent just so recently, and it just kind of because of the pandemic, and now that it's like going into the language of contracts when before it probably wasn't as prevalent, just based upon what I understand from listening to the both of you. That's all.
If there's a cause, I would guess that maybe there's some, and this is a guess because we didn't look into this, but maybe there has been heightened levels of enforcement as political entities trying to trundle down and attack Medicare and Medicaid services in general.
Yeah.
And then those are restricted further because of the money constraints on a government level. And so you wind up with greater watchdogging. And maybe there's been an acceleration to that. It was super popular a number of years ago when the regulations kind of came in. You probably recall some stories about things like physical therapy organizations. Those people used to make $500,000 a year because there was so much inbred triple billing crap.
And they controlled the number of grads as well.
Yeah. And that finally, some of them met their maker out of that routine. And it could be just a rejuvenation of enforcement. The kickback issue relates to, there are obviously civil penalties too, but it can go right down to criminal activity. And so I'm sure you got some people just absolutely terrified that they did something wrong. So they're making rash decisions when it comes to that.
Okay. Well, my last comment is then I'm surprised then that, so I don't know if you're familiar with the concept within banking of the glass wall, right? Or the glass segregation between the buy and sell side. I'm not sure why they wouldn't have implemented this, the same concept between the provider side and those that give services or support the providers, right? You can't breach the wall between the two and actually see what each other's doing, so that you segregate it internally between the provider and those that are providing those support services. And I'll be interested to see if that will be something that would happen and follow in that sort of model in the future as well.
Yeah. I would say you find it in the compensation package by not rewarding people for recruiting and referring.
But then that would be subject to each individual contract, not like across the board or within an institution then, right?
Well, but if you leave the recruitment to non-healthcare providers, advertising, etc., and you don't reward in compensation tit for tat kind of reciprocity for recruitment or referral to the provider, then you've got that under control. And remember, some of these are institutions that are forbidden from doing these kind of kickbacks too. So in no way can the institution make an arrangement that creates that. That's both Stark and anti-kickback have that element. But the glass wall, or in legal ethics it winds up being called the Chinese wall, whether that's anymore, is an idea of how to limit information flow. This is more task oriented, I would say, and so it's more verb than noun.
Okay, thank you both.
Yeah. Other questions that are perking up. There's still a lot to learn to sort of just let this be, for me, very, very familiar. But it's clearly impacting some midwives.
So Ginger, I'd just like to ask a question kind of at the professional organization level. Do you know, I mean, you know all the midwives in the country just about. Are there midwives that can do this research that maybe just don't know it needs to be done? And like, what can we do as a professional organization to collect this data and start reporting it and really move our profession forward in a way that compensates midwives for the work they do? I mean, where do we go? What are our options?
Well, I asked when we first started, so fall of 2017, when a new salary survey was going to be done. And at the time, we did not have a researcher on staff, and the Division of Research didn't pick it up. And so a year or two later, I brought it up again when we had a new executive director, and it was going to be a priority. And as far as I know, I have never filled out a survey since 2010 about my salary. So we still haven't had one done. And I guess you could make it a motion at the annual meeting. You can make it an action item for a board meeting. You can talk to your regional rep about it, but it is crucial information that we have got to understand.
So
there's also an opportunity in professional development. You know, in law, we've started doing combined degrees like social work and law, MBAs and JDs, those sorts of things. And I think educational institutions could really find a niche offering programs like an MBA,
Oh yeah,
CNM, or not MBA, nurse midwife degree, or other hybrids. Alvin may have just left this, but he's similarly gifted. And if you had that in the education program, which you have, would be people trying to get their master's thesis done and doing these various kinds of investigations.
or a doctorate.
Sure.
Yeah. Huh. Well, it's certainly something to think about because it needs to be done. What about midwifery works? Is that, I mean, that's the business side of midwifery. Is there no one in, I don't, you know, I've been to a couple of the meetings, but I don't really understand their structure, even within ACNM. I mean, I know that they're like kissing cousins, but is there a structure within midwifery works that we could go to and say, you know, this is something that we need to take on as a
I think they could influence. I think they could influence the national office, but this is a national association survey.
Right.
And it would even be better if it were an AMCB survey, because we only have about 54% in our organization.
That's very true. That's very
AMCB is likely not willing to do it because it doesn't affect quality or safety. It's very difficult to do research through AMCB's database. So, you know, it has to be done, I think, through the national organization. The tools designed might want to be tweaked from 2010,
Yeah.
but not that much. It just needs to be done.
Yeah. Yeah.
You know,
Well, I'll make a motion.
I'm going to head out.
thanks, Joe.
I just wanted to say thank you both for this. You know, it's a lot to digest.
It is.
All the legal terminology spins my brain, but I appreciate you breaking it down for us in digestible bits so that we can use this. And Ginger, you know, because she's helping me with the program here at UT HSC, we are planning to infuse some of this through our education program. So we'll just have to see how that works out, because I mean, my business knowledge could fit in a thimble, but I've got time to learn and to look for resources that might help us. So thank you. I appreciate it.
Lindsay, I have not filled out an annual benchmarking survey tool in a long time. Do they ask your salary in that benchmarking tool? Are you reporting salaries? If Lindsay's still with us?
So yeah, I am. Sorry, I was brushing my teeth.
That's okay.
I like midwives multitask, we know that.
That's right.
So in the benchmarking survey, they ask the salary, including all bonuses, and then how many FTEs are in the practice. When I was doing our benchmarking survey this year, I think we have a new manager, and I had to ask her 3 or 4 different times to give me the right number, because I'm like, well, that one would nope, that one's way too high. And then I'm like, nope, that one's way too low. And then, finally that one sounded reasonable. But so, and then it will tell you the percentile compared to other groups of your size. So again, you don't have to fill out all of that information, but that is always one that I really try to get an accurate number on, hoping that they did something with that. I thought if anything else, I do feel like in our group, we are pretty fairly compensated, and when we've fought for an increase in salary and they insist there's federal laws, we can't pay you any more than we are, we say, fine, we're just going to work less. So now we all work 3 days a week, which has been lovely.
Oh, wow.
So we haven't necessarily been able to negotiate for more money, but we've negotiated for less time.
Yeah.
Which has been great for us.
Yeah.
But I say, if anything, if we can get that information about our salaries out there and it can help someone else, then that's a number I really want to be accurate. So.
Yeah, I've never seen any aggregate benchmarking data published.
Yeah, I haven't either.
Ever.
Which is too bad, because I don't know how many groups do it, but.
Well, this is why they cannot publish benchmarking data. It is not a formal IRB approved data set.
Sure.
And you cannot publish in a peer-reviewed journal without IRB processes. So all of that information,
even if it's secondary data,
is held in-house. Yeah, that's the standard.
You would think with secondary data collection, if there's no if there's no identifier.
Have you seen anybody publish benchmarking data? Never. It's reported out. People talk about it, but no, there's been no published findings of any kind.
So why have we never sought IRB approval for the?
Because we don't have a department of research in our association. We don't have a funded position to manage this. We used to years ago.
Didn't we?
Years ago. Yeah.
We had to cut it in budget cuts.
It was a budget issue.
Oh, Lord.
Well, I tell you, we have not got it all. We haven't got all the legalese cracked yet, but we're working on it as we find more and more things out that are thematic in contracts. It's a backdoor way to talk about the business of midwifery and compensation, but I'm tired of seeing the Medscape salary survey show midwife salaries are dropping and everybody else is going up. And if that happens again this year, you better believe I'm going to start jumping up and down, screaming at somebody, because we cannot continue to have our salaries drop when they should be going up.
No, not for the work that we do. I mean, and again, I'm gonna Google some of this CRNA compensation, because I've actually been thinking about it quite a bit, even before I knew about this webinar. It's kind of been on my mind, like, why do they make so much money? What is
Start with the Bureau of Labor Statistics. They've probably got the most accurate data, and there are a lot of CRNAs compared to our small N that's reporting, right? So their data is much more likely to be accurate than ours. Yeah. All right, you guys, thank you for being with us tonight. If you like us, give us some love. We'd appreciate that. It'll keep us motivated, and we're glad we're helping a little bit. We really are.
You're helping a lot, and we appreciate it, Ginger. Thank you so much.
All right, you guys. Bye-bye.
Thank you, Ginger. Thank you to Joe as well.
Yeah, thanks, Alvin.